thankful to you for giving time for this PG masterclass of IMM, which has been organized by Dr. Sonal, Secretary IMM. I'm really thankful to her utilizing her resources from the institute. And as you all know that Dr. Chakrabarti really do not know any introduction. We are always late. But I just wanted to tell that Dr. Chakrabarti at present is working at Dudahari Barfani Hospital and Research Center, Haridwar as director. And he has been the head and professor at Medical College, Medical Microbiology, PGMER, and has been the president of International Society of Mycology, ISAM, and he was chairperson for the international conference, which was just completed in the 2022. And he has around 400 publications to his credit, and around the 2022 awards to his credit, and have contributed in around 50 books. So his contribution, particularly in microbiology, is well known not only across India but across the globe. So without any delay, I look forward to listen from Dr. Arunaloke Chakrabarti and hand over to him, who will be speaking today on null culture based diagnosis of fungal infections. Dr. Chakrabarti, over to you.
Thank you, Professor Sherwal. Good afternoon, ladies and gentlemen, and I hope you can hear me. At the outset, I like to apologize for the delay in connecting this particular webinar. I also thank Dr. Arti for giving me this opportunity. She is at present the president of Indian Association of Medical Microbiology. At the same time, I also thank Dr. Sonal Saxena, the Secretary IMM, who have taken such an initiative. My talk today is a very important issue. I'm not very sure how much you appreciate this particular factor, that is diagnosis of fungal disease. Because if you see, concern about fungal infection compared to bacteria and virus is of recent origin. We started realizing this particular disease as an important in 1980s with the emergence of HIV, transplantation, immunosuppression, and more medical device use. But within short period of time, it provided a formidable challenge because of high morbidity and mortality. And India has got a very high burden of this disease. We do have also an unique epidemiology because India has got a tropical climate, and here we have a very high patient load in our public sector hospital. So very often there is compromise in healthcare. And also what we have seen in many studies, the spores in the air of the hospital or even in the environment of the community, there is very high number. So we do see very high incidence of fungal disease. And over the years, we also seen there is a change in epidemiology. But to face this challenge, the main problem is we have limited awareness about fungal disease. We do have very few fungal diagnostic laboratories. And even we need a training in case of fungal diagnosis and management. Very recently, we tried to see what is the total number of fungal infections in India. This is a projecting data which we have just published. It shows 4.1% of the people suffer from serious fungal disease. And if you compare between the fungal disease with the tuberculosis and malaria, where we pay a lot of attention, compared to malaria, any of the fungal infection numbers are very high. Even if we add together all the fungal disease, invasive fungal disease, it would be comparable to the tuberculosis. I tried a comparison regarding the burden of the 6 populous countries regarding fungal disease. And if you see, in case of India, in Candidemia, it is second to Brazil in number. I am not sure why it had shown such a high projection of aspergillosis in case of China. Even then, India comes second to it. And in mucormycosis, none of the other countries could show their bird almost at the base level, but India has got the highest in number. So if we see in India, we do see invasive candidiasis is a very important factor. And in this invasive candidiasis, the challenge which we are facing about the multi-drug resistant Candida auris. I'm not very sure whether all of you have heard about this problem. I have made a slide of it. I'll just talk when it comes of Candida auris. But at the same time, I like to highlight that there are several outbreaks which have been seen in India due to the rare yeast. And in this rare yeast, the problem comes that we don't know the epidemiology. And here we don't know what is the environmental reservoirs of this, so control is difficult. And by the time we identify the outbreak, it had spread to the large number of patients. So here laboratory diagnosis remains a challenge. And if I have to do the susceptibility testing, we don't know what is the antifungal breakpoint. After Candida, it is Aspergillus and Mucor are important, but at the same time, I like to highlight that the black mycelial fungus, Demeticious fungi in CNS infection is becoming important. We see like Cladophilofora Bantiana brain abscess, almost 50% are in India. There are also rare molds like Scedosporium and Fusarium, which is also causing invasive disease. Now, any of this, whether it is you look into invasive Candida, invasive aspergillosis, or mucormycosis, if you delay the diagnosis and delay the therapy, mortality increases. Now, because of lack of diagnosis, clinicians, what they try to do is that they go for empiric therapy. They like to sleep after giving antifungal in their patient. But we need diagnosis. And here, if we see the ratio of empiric and targeted therapy in any hospital, that determines your effort in case of diagnosis. So friends, at present moment, the current diagnostic methods diagnoses the cases when there is clinical infection. And this clinical infection means when there is symptoms and signs. But then we cannot save many of the patients because it is already late. We need to do when there is entry of fungi in the body, that is the biological infection, and here it is the biomarkers which are useful. Now there are biomarkers, mostly people know the fungal biomarker, but now we are working also with the host biomarker, especially the genetic susceptibility that would help in case of understanding which patient we need to take care. Amongst this fungal biomarker, existing biomarker which is already standardized is because of galactomannan, beta-D-glucan, and Aspergillus PCR. Galactomannan in case of serum and BL, and beta-D-glucan in case of serum. But what are new? First important thing is that now we are entering in the era of point of care test. Lateral flow assay in case of crypto, Aspergillus, and histo has become very important. You know, in case of this biomarker test, like in case of galactomannan, beta-D-glucan, we need batch testing. That is, number of patients required where you have to do first providing a test. But many small laboratories do need a test which is for a single patient. And there would be really delay in diagnosis if you have to wait for more number of samples. So here, both in case of galactomannan and in case of beta-D-glucan, we have now single testing available. In mucor, there is PCR which is coming up and many molecular tests are in pipeline. IL-8 detection is also becoming important, but I'm looking forward to this area of cell-free DNA detection and genetic susceptibility. So existing biomarker is more suited for ruling out any fungal disease rather than ruling in invasive fungal infection. That means if you have got a very high risk group where you can say that at least if it is negative, that means we can rule out the fungal infection. Turnaround time also depends, as I've mentioned, about the test frequency and molecular diagnosis. We compare to the bacteria and virus, there is small number of fungal pathogen. That's why sensitivity is still low. Now, taking example, what are the dilemmas? What do you face in the world? Clinician face first dilemma in case of the sepsis. If you have isolated bacteria or fungus, that is fine, but good number of cases you are not able to do. So what you are doing is that you are giving both antibacterial and antifungal. That's why we, about 5 years back, made this provocative statement. We said delivering on antimicrobial resistance agenda will not be possible without improving fungal diagnostic capability. So, friends, if we have to stop this, we need good point of care tests. We need early and accurate diagnosis in case of fungal disease. Now, coming first to the invasive candida, invasive candida, basically we see either candidemia or localized deep-seated infection, of which abdominal candidiasis is one of the important. They enter the blood vessel either through the skin or mucosa or from the gut, depending upon the various risk factors. Now here, intra-abdominal candidiasis is becoming important, and here repeated perforation, anastomotic leak, necrotizing pancreatitis, these are the very important issue where we need to diagnose these cases. Why I am emphasizing this area? Because intra-abdominal candidiasis diagnosis is a major challenge. You know that in case of the invasive candidiasis, blood culture positivity is the gold standard. But in case of autopsy-proven invasive candidiasis, we found that the blood culture positivity varies from 21 to 71%. That's very wide variation. And in intra-abdominal candidiasis, blood culture positivity is less than 15%. Moreover, the turnaround time in case of blood culture is 2 to 3 days, which is possibly not acceptable in case of fungal infection. So we need improvement in diagnosis. One method had come out is the T2 magnetic resonance nanoparticle based detection. If you see here, the turnaround time, which was earlier in blood culture 106 hours, had come down to 4 hours. But problem here in case of this T2 is it is only identifying 5 Candida species. When we did a study across India in 27 ICU, we found in India in bloodstream infection 31 Candida species are important. So here T2 magnetic resonance nanoparticle based technique may miss many of the cases. Second important thing is that this test is very, very expensive, and till now it is not available in case of India. Whereas if you see this MALDI has really improved in case of both bacteria and fungal diagnosis, because it can identify the yeast and mold within no time, and very soon possibly we can do the antifungal susceptibility testing. Now, coming to the biomarker in case of diagnosis of invasive candidiasis, most popular biomarker is the 1,3-beta-glucan. Otherwise, Mannan, anti-Mannan, Candida albicans, germ tip, antibody test, or multiplex real-time PCR, that can also help. I've already mentioned about T2. Now, this 1,3-beta-glucan test, this is from Limulus. It is the lysate which is collected from these horseshoe-shaped crabs. And this particular test for endotoxin detection was well known for a long time. Now, here what it had been found that there is another arm which is being stimulated by 1,3-beta-glucan. Now, this particular arm can help in case of detection of this fungal diagnosis. There are batch tests, there is single test, I'll come to it, and it can combine with other tests to give a better diagnosis of fungal disease. Now, if I have to compare the beta-glucan assay of different procedure which we have at present, I would still say that FDA approved test is only the FUNGAL test, which we generally do. Now, in FUNGAL test, what is there important is that we need at least 21 patients. So this is the batch testing which is required for doing the test. As I mentioned, in a small laboratory, it may not help. That's why this is a new method which had come, that is the FUNGAL stat assay, which allows single patient testing within 1 hour. And the results could be correlated with the FUNGAL assay very well. So this can replace very soon near future. Now, if I have to say 1,3-beta-glucan, where it is useful, this is a very important study which have been conducted at Apollo Chennai. It was Dr. Nandini she conducted along with the clinician. What they have found is that suppose you have started antifungal and your patient is showing beta-glucan less than 80 picogram, you can stop the therapy. This is tremendous importance in case of antifungal stewardship. This particular test is also useful in case of the intra-abdominal candidiasis, especially as I've mentioned in blood culture, positivity intra-abdominal candidiasis is very low, so it can be useful. It can also be compared the T2 versus beta-glucan. T2 has got better specificity but low sensitivity, whereas 1,3-beta-glucan has better sensitivity. Now, what we can do is that we can combine the two tests if possible to improve the diagnosis. So, friends, if I have to do the recommendation on this basis, though this particular table shows also of invasive aspergillosis, let's look into invasive candidiasis, which I have just discussed. One is that whether negativity can exclude this disease or positivity if can confirm the diagnosis. In hematologic cancer, we cannot exclude, but if it is combined with the URTC, MSG, other classification, it can help in diagnosis. In solid organ transplant, other immunosuppression, rather, it can help in exclusion of invasive candidiasis. Whereas in ICU patient, what you can do is that here it is again can help in exclusion, and also if the patient is in a high risk category, 2 consecutive positive cases may help also in case of diagnosis. But beta-glucan also lacks specificity. This is a very interesting study. Had been compared the open intestinal surgery with the laparoscopic surgery. In open intestinal surgery, the false positivity rate of beta-glucan is much higher than the laparoscopic surgery. And this happens because in these cases, we do have gut leak. That is you can see here prior skin incision, after skin incision, after anastomosis. So you can see there is a gut leak, which is very important, leaky gut. And here sepsis, liver cirrhosis, dialysis, post-abdominal surgery, where also it can be false positive. It can be have false positive in case of medication, infusion, medical intervention, and bacterial infection. At the same time, false negativity in case of hyperpigmented serum, if already patient is on antifungal or azithromycin and pentamidine therapy. A lot of clinicians ask me, can you not do procalcitonin level as a biomarker for diagnosis of Candida? The reason why they try to say is that in case of bacterial sepsis, procalcitonin level go high, but it doesn't happen in case of virus or in case of fungus. So can it be used as a indirectly as a biomarker for suggesting it is invasive candidiasis? So this is a meta review, that is a systematic review of 16 studies which have shown that the evidence supporting this observation is of low quality and the difference seems insufficiently discriminative to guide the therapeutic decision. But what I find is that if we can combine with the beta-glucan with procalcitonin, that is very useful for increasing the sensitivity or positive predictive value. Possibly in negative predictive value, it is not so much useful. Menon anti-Menon test, I would say that this particular test is not so much become popular because of the variation of the sensitivity. It had been used in case of European centers, but hardly any other centers use this. Similarly, in case of Candida albicans germ tube test antibody, it is also variable sensitivity. That's why people are not using this. Somehow Candida PCR, which should have been a very simple test, it had been found that the interpretation of the PCR is more complicated than beta-glucan. That's why people are not using, though there are certain studies where especially meta-analysis showed good sensitivity and specificity, but even then, I would say this Candida PCR is not so widely used. So if I have to sum up in case of invasive candidiasis, what I tried to tell you is that positive predictive value is not so good, but negative predictive value is good. But we don't know what is the threshold that should be used. If the negative predictive value is more than 85%, at least it can help in case of antifungal stewardship, but don't go for these tests indiscriminately, because in a low positivity rate in patients, there cannot be this test may be very useful. Now, as I mentioned, Candida auris. Candida auris, the importance of this is, it is a fungus which is behaving like bacteria, developing resistant very fast, easily transmitted, contaminates the environment, cause severe infection, not easily identifiable, and cause multiple outbreaks. And very recent study, it has shown that in case of bloodstream infection, which was earlier 6th rank in order, now it has become the 1st rank in order in case of Candida auris. So we need, if we have to stop entry of Candida auris in your hospital, we need to identify it quickly. Can the chromogar useful in this regard? First thing is that chromogar takes at least 24 to 48 hours, and there are a lot of confusion if there is Candida parapsilosis and Formota is there. I'm not very sure, but you can try this particular technique which people are evaluating now. There is a diagnostics have developed this, which says that the sensitivity and specificity is good, and turnaround time is within 1 to 1.5 hours. You can say this, that there is Candida auris or not. This would help. Suppose the patient who have been referred to your hospital in your ICU from another hospital, whether the patient is already colonized with Candida auris or not, you can collect the sample from the axilla, groin, as well as from the nose, and can try to see this aspect. Now, coming from this is to the challenge in case of the mold diagnosis. First thing is that till now, the diagnosis of mold infection faces the problem of limited awareness. You do not find what you are looking for unless you are trying to move. Sorry. Limited awareness is that you do not find what you do not look for. That is very important issue. You must think about it. So here, if you are even aware, there is non-specificity in symptoms and signs. Imaging is also non-specific. Like suppose earlier we used to see this mold infection more in neutropenic hosts. So here what it used to happen, the spores after entering in the alveoli, it enters the blood vessel very fast. So this is producing this halo sign or air crescent sign. But now we have got more other host factors like prolonged ICU stay, influenza, all these situations. What it happens is that they enter in the alveoli, but they don't enter in the blood vessel because there is neutrophil which is protecting. So you get non-specific imaging like localized bronchiectasis, tree-in-bud appearance, ground glass opacities. These are the things which you see. So shall we just discard this conventional diagnosis and go for non-culture based only? I would say that still in case of mold infection, conventional diagnosis has a lot of role to play. Because first thing is that by direct microscopy, it gives the result very fast. If we see fungus in a deep-seated sample, that's a proof for fungal infection. You can identify the fungus, do the susceptibility. And now people say that for deep-seated sample, the problem the patient is having thrombocytopenia. I rather suggest that give a platelet infusion and collect the sample quickly. Respiratory physicians are improving our diagnosis by doing bronchoscopy and EVAS. Sometimes samples land only in case of histopathology department, and histopathologists cannot identify the species of fungi. You can do immunohistochemistry, or you can extract the DNA and do the sequencing for identification. Now, culture of the respiratory secretion lacks sensitivity. That's a big problem. And you know, in case of immunocompetent host, this is mainly colonization if you have recovered it from the lower respiratory tract even, but only strongly suggests invasion in immunosuppressed hosts. So we need these biomarkers. Most commonly used biomarkers is the galactomannan. Galactomannan, now there is more tests are available. It's not only galactomannan, manoprotein specific for aspergillus has also come up. And here it is well standardized in case of blood and bronchoalveolar lavage. People are trying to standardize in case of CSF and peritoneal fluid, but you must be careful in case of false positivity. Again, medication, infusion, medical intervention, even a patient who has taken pasta just before the test or yogurt, they can give a false positive result that is there. Even environmental positivity is a big problem. Now, the biomarker in case of galactomannan, if you see in traditional risk group, sensitivity highest in case of stem cell transplant group, but specificity is still a problem. So I would rather say that BL sample is better. Here, sensitivity and specificity good. Even the galactomannan, though it is not well standardized in case of ICU patient, but it is improving the sensitivity of diagnosis in these cases. Another test, I would say, that simply coming up, that is like in case of beta-D-glucan, it can perform the test in a single patient. That is Aspergillus galactomannan. This is mono test. This is chemiluminescence based, and this single testing is possible. And it has, when compared with Platelia, shows rather good sensitivity and equal in specificity. But this is my more attraction. That is the point of care test. And in case of Aspergillus, the lateral flow assay which have come up, there are two methods which are there. One is of IMI, another is the OLM. One is detecting the protein, another detecting the galactomannan. Both of these sample testing wise, it is similar. Small volume sample, turnaround time is only 15 to 30 minutes. And if you see when it had been compared with the BL galactomannan, it is showing very good result. And when there is a head-to-head test comparison between this lateral flow and lateral flow device, it had found that the lateral flow is giving better result rather than lateral flow device. Though I want to evaluate, that's been going on in case of India in multicentric study. Very soon you'll see the result, whether this test can be reproducible or we should do one particular test. This is one test which is still slowly evolving, that is urinary antigen detection for this particular monoclonal antibody, that is the galactofluorono specific monoclonal antibody, that has shown very good sensitivity and specificity, but it is still waiting for commercialization. Some people tried with this secreted siderophore of Aspergillus fumigatus, that is the triacetyl fusaridine C detection. When it has been combined with the galactomannan test, it shows very good improvement in sensitivity and specificity, but it still needs standardization. Friends, you know, in case of mainly mycelial infection, though it is also used in yeast infection, in case of immunosuppressed, especially neutropenic hosts, the URTC and MSG, they combinedly proposed a classification depending upon the host factor, clinical factor, and mycological factor. Proven cases, probable cases, possible cases. Now, proven cases is very well known when you can demonstrate the fungus in the tissue. But it is the probable cases where the maximum attention is going on. Now, with the standardization of the Aspergillus PCR, it has been incorporated in the mycological evidence. But it is said that you should do the test only in the laboratories with proven record. Now, this is okay when you have neutropenic host. What about non-neutropenic, like in case of ICU? And in case of ICU, we don't have the host factor, that is the patient should be immunosuppressed or the neutropenic. So here, there is a procedure which had come up and proposed, that is the Aspergillus present in the respiratory tract culture, or you can do the galactomannan or PCR. And then if there is at least one symptom, if there is host factor and if there is imaging, at least abnormal imaging, then you can think of diagnosis. So these are the host factor. You can see, of course, these are the neutropenic patient, non-neutropenic patient like COPD, cirrhosis, influenza. Here, at least if you have got clinical presentation and mycological evidence, you can try, but specificity is still not above 70%. Now we have seen another problem in case of invasive aspergillosis, especially pulmonary aspergillosis, that is virus related. One is influenza associated, another is the COVID-19 associated. Influenza associated, we are seeing in last decade, around 10% of the patient during this influenza outbreak, they have this pulmonary aspergillosis. Here the diagnosis is not a big problem because quite a number of patients tracheobronchitis is there. So if you do the bronchoscopy, you can easily pick up the sample and can diagnose. And here even the galactomannan, both BL and serum is good. But when this COVID came, this COVID also is diagnosing around 10%. But here the problem first is that tracheobronchitis are very few, and serum galactomannan, which is most likely people like to use, that is not good one. So it remains a big challenge in case of diagnosis. And here the problem is, again, it's immunocompetent patients mostly. So you cannot put URTC MSD classification. People tried with the Aspergillus ICU or the influenza associated pulmonary aspergillosis guideline. When they try to look into imaging, confirm aspergillosis and without fungal infection, the COVID patient, their imaging cannot distinguish. So there are several definitions which have been tried, and when this has been compared, it found that this definition way beyond. Means I am saying you can see there are so much variation which is there, but what it had been found is that if you can do BL galactomannan, that is useful. Now, people at the beginning of the COVID were scared to process respiratory sample. So we suggested, this is our recommendation from European Confederation of Medical Mycology and our International Society together. We initially said non-bronchoscopic lavage you can try to do. If it is titer is very high, you can do it. But then finally 28 experts group sat together and found that at present we have got good knowledge about COVID. We can do respiratory sample collection. We need bronchoscopy and BL galactomannan for diagnosis. It would not help with CT or serum galactomannan. Now, IL-8 detection is still in the process. It has been found that it is very well associated with invasive aspergillosis. But I would say that this is still in the infancy. We need to look into this particular procedure. For mucor biomarker, it is the mucorales PCR. One of the kit had come, that is from Netherlands, one of the company who brought it. In case of COVID-associated mucormycosis, we didn't find this particular test is much of useful. But this particular paper, which had come last year, that is the qPCR, and this has been done at 9 university hospitals in France, where it has shown good sensitivity and specificity of this test. Most important thing, what they have shown is that before the conventional diagnosis, 4 days before they can diagnose these cases, and when this test becomes negative, mostly the patient come out very well. That means their success in those patients which positive becomes negative shows that good prognostic value. But again, I would say that this test needs to be evaluated in more number of centers. Not only aspergillus or mucor, we also face the non-aspergillus invasive mold disease diagnosis, especially like Scedosporium, Lemanthospora, black mycelium mold, Fusarium. There is nothing is there. But I am just looked into this. This as a proposal which is being there that treating physician should suspect it. Consider immediate initiation of therapy if the clinical picture and other tests really helps. Test generally is the imaging, blood culture, samples to be collected. If possible, histopathology is very important. Galactomannan is useful in certain cases, but beta-D-glucan, in mucorales it is becoming negative. But we need some pan-fungal PCR which can be there. But pan-fungal PCR, this is an Australian study which are tried with the ITS-1 pan-fungal diagnosis. I'm not going into the details of this particular study, but what it has shown that if the histopathology is positive, then it can really help in case of diagnosis. Otherwise, it is not helping. Now, many molecular diagnostic tests are in pipeline. Very soon, possibly, we can have multiplex PCR for fungal diagnosis. In case of histoplasma, also we have a lateral flow assay now, and two companies, both of them claim good sensitivity and specificity. But where my attraction is going on for my younger friends here, this is something which is evolving in case of whole microbiology, whether it is bacteriology, fungus, virology, everywhere. That is cell-free DNA detection. It first came in case of the cancer patient, but now it is in microbes. It is very useful, especially whole genome bisulfite sequencing, and along with, if we can do the cytosine methylation of this cell-free DNA, it can not only detect the fungus, it will also say which tissue is get damaged. And some of the versions which have been already been tried, like this is one of the tests which have been tried in 226 patients. What they have done is that they have used this 12 particular panel, 12 fungus which is commonly being used. Most important thing is that it would change the clinical management in nearly 50% of the patient. Only thing, it is not so good in aspergillus, but it is good in case of mucormycosis. Similarly, this is another test which have been tried, that is with the samples which have been preserved. And here also, if you see, combining with the galactomannan gives good result. Here also they found problem remains in case of aspergillus, which needs to be done. Now, if I look into the host biomarker, I'm just going to finish it because this is at the immature stage or at the preliminary stage where people are trying to look into it. Especially one aspect is that if we try to do in case of cytokine, that is the mutation, if it is being present, define cytokine. And here if you see that certain cytokines, if it is being present, that is being correlating with the high risk patient. But I'm not very happy with this type of polymorphism experiment because it requires large number of patients, which is not so many have been diagnosed in case of fungal disease. But this is a signature which is coming up, which is very useful, like matrix metalloproteinase. You can see it is in case of invasive pulmonary aspergillosis going up, whereas in galactine, it is going down in case of the probable invasive pulmonary aspergillosis. So two centers, one in Germany, another in case of UK, evaluated it with the same samples. What they found is that there is MMP1 and IL-8 and caspase-3. These three can be useful in case of possible future diagnosis. Similarly, in case of candidemia, they tried with this transcriptome response, 48 patients, 30 healthy control. They did the RNA-seq, and what they found is that, yes, certain are specific for Candida, but till now, this is at the very preliminary stage for giving the diagnosis of Candida. So friends, summarizing what I tried to tell you, in case of diagnosis, first think of fungus in your patient. Lateral flow is my most excitement because it is giving point of care test. And this improvement in case of fungital as well as in case of galactomannan detection, that is really very important. I would say that invasive aspergillosis diagnosis is still, I see, a challenge, especially with this type of infection like COVID associated or influenza associated pulmonary aspergillosis. Mucormycosis, yes, that is a big problem for our country. I would encourage all of you, please do study in mucor for a biomarker. But in future, I am looking for the cell-free DNA detection that would be very important in fungal diagnosis. And of course, certain host factor which may act as a host biomarker for giving you the diagnosis. So present biomarkers, I would say, if clinicians are very attentive, they can allow diagnostic and therapeutic anticipation, reducing mortality. Especially if you have started therapy, you can discontinue the therapy, and certain times you can withhold the therapy. Otherwise, you will give on giving empiric antifungal without much useful. But whatever I may say, I would say that we need better biomarker and commercial molecular diagnostic tests. Finally, I say that we do have a fungal India registry. Here, any case of mycelial disease or in case of rare fungi, If you submit, you can go to this FISF website. If it is accepted, we per case reimburse 2,000 rupees. Thank you all for your kind attention. I hope I could give you certain glimpses. I know it's a big challenge in case of diagnosis of fungal infection. Now, if there is any question, please ask me. I am there to answer your question. Thank you very much.
Thank you so much,
Thank
sir. I
you.
think questions can be
Sorry.
put in the question box if there are any. Ma'am, yeah, I hand over to Dr. Aarti, please.
Thank you so much, sir. I think what a subject which is so relevant in the present times. And you all know, and we all know, that diagnostic stewardship is now the thing in which these tests, the non-culture based, the point of care, the rapid tests are going to have a lot of place. And for antifungals, we have very little information. So I think this was really the whole information into a small capsule. I hope our students understand the importance of the effort that has been put in. So thank you so much, sir. I really enjoyed. Thank you. Dr. Sonal, please.
Yes, thank you, ma'am. Thank you. At the outset, sir, a very, very big thank you to Dr. Chakrabarti for taking out the time here and out of all a busy schedule of a director at a hospital. Thank you so much, sir. And I'm sure the students must have benefited. For the benefit of the audience and the panelists, there was a maximum attendance of 427 people today, and we had 704 registrations, out of which 420 joined at one particular time. Now, so there are no questions put in the question box. Just let me see. I think everybody's just got praise for you, sir. There are no questions. Somebody has asked biomarkers, but I think you. So there is just one question. Any biomarker for diagnosing mucor, especially in urine? And what is the role of beta-D-glucan in pneumocystis infection?
Both these questions are very important. You know, in case of the mucor, rather I encourage all of you, please do certain research for diagnosing this mucor, because mucor is our problem. None of the other Western world is trying so much in case of mucor for diagnosis as it should be done at our place. Very recently, one of my PhD student had come up with a particular marker or signature. We still try to look into this aspect, whether it would be useful or not. And you have seen that this mucorous PCR, which possibly may be very useful in future. One important thing, what you have asked about the pneumocystis vis-a-vis the beta-D-glucan. I would say pneumocystis is one of the infection where beta-D-glucan goes very high. Rather, two infection where beta-D-glucan is very useful. One is the invasive candidiasis, another is the pneumocystosis. Beta-D-glucan can be positive in Aspergillus. Beta-D-glucan can be positive in many other fungal diseases. But these are the two infections where beta-D-glucan goes to the roof, nearly 500 picogram, which comes in positive. So in a patient where you are suspecting pneumocystis, beta-D-glucan is very, very useful. Now, pneumocystis has got one of the tests. I could not discuss all the points, but pneumocystis has got a test which is the real-time PCR, and this real-time PCR can distinguish between colonization vis-a-vis the pulmonary infection. So you can see that Dr. Shiva Prakash has published that paper as the first author, and that particular paper has been evaluated in many centers. Now this is very useful if you do the quantitative PCR in case of distinction between this pneumocystis colonization vis-a-vis infection.
Sir, there are a few more questions. One is, what is the best way to detect Candida auris infection?
I would
Dr.
say
Pooja.
Candida auris infection till now, I'm not very sure about this uh, phenotypic tests. Like people claim that they can diagnose this. Uh, One of the paper, if you see in Journal of Clinical Microbiology, Anup Ghosh has tried with detection of a selective media. He used certain selective agents for doing this, which needs to be evaluated. But till now, I'm more confident only with the MALDI if it is giving the confident diagnosis. But I'm sure all the laboratories will not have MALDI. But if you see any time any yeast which is something bizarre, not common, like suppose Candida uh, sheki, there is a Candida sec culture which have been found out, or sometimes like in case of Candida, different other species which is not commonly heard, then think about, can it be Candida auris? Try to contact a reference lab to help in this regard. I would say that this OLM PCR kit, though the kit is a bit expensive, but if it can help in case of Candida PCR quickly, in case of diagnosis, because it gives result within 1 to 1.5 hours. So that might be useful in that situation. So we need some phenotypic test in case of Candida PCR, because I'm not expecting that tomorrow every laboratory would have MALDI or have the molecular test. So there is still scope for improving in case of Candida auris diagnosis. But anything, any yeast which hard to be very peculiar, when you have done with the phenotypic commercial system and think about, can it be Candida auris? And especially Candida auris grow at a higher temperature. That should also be remembered. It can withstand up to 40, 45-degree temperature. So that's also very important.
All right, sir. So there are a few more questions. One is that what would you recommend that should, I don't know what Mr. Sriram is asking this. Among the many tests you have mentioned, which two would you recommend to be combined for better diagnosis of fungal infection? I think that would depend on the what you
That,
suspect, but
that's already is being answered. Is if we have to do that two tests, one should be galactomannan, another should be beta-declucan. These are the maximum evaluated, well standardized, and can be evaluated much more. So that these two tests can be very, very useful. And when lateral flow is coming up, I think it would be much easier to do this. Only thing is that these tests are still very expensive. I've discussed with all these manufacturers that you have to reduce the cost. But you know, when they say that echinocandin one day dose costs 12,000 rupees, he said you don't hesitate to give echinocandin uh, empirically, but you hesitate to do the test. And in case of beta-glucan test, generally in our PGI, it is being done at 3,000 rupees, but commercially it is around 10,000 rupees. But if you see one dose of echinocandin is 12,000 rupees. So don't get discouraged for doing this test. Of course, we need the test should be further cheaper. Uh, but if you are using more in centers, of course, it would come down.
so false positivity in galactomannan detection is a big problem. So any way it can be ruled out?
No, I always say that none of the biomarker tests really helps in case of confidently the diagnosis. It only gives a suggestion. It only gives a support for your own suspicion, whatever you are thinking. That's why I said that biomarker tests rather exclude the diagnosis rather than putting in the diagnosis. And you have to be very careful in these cases. Like suppose, as I mentioned, galactomannan, even taking ice pop, it has become positive. After taking yogurt, it has become positive. So, so many issues are there in case of this false positivity. You have to be very careful.
So any false positivity or help that it gives in nocardia infection, somebody is asking.
Nocardia or some bacterial infection it can become, but nocardia it has not been said so much. It has been said with case of alkalizis, fecalis, and several gram-positive bacteria where it is being positive. So I would say that in general you can take it in consideration if there is a mixed bacteria and fungus infection, it may give a false positivity. So I would rather suggest you, if you are doing regularly galactomannan, instead of doing once, say suppose if you have got a patient whom you are suspecting that there can be a chance of invasive aspergillosis because of so many other risk factors, like this patient is influenza associated, like this patient is staying in ICU for a long time, like this patient suddenly you are seeing some imaging shadow which had come up in CT, which may not be that it is the having that same ear crescent sign or halo sign, but there are certain imaging shadow came up, like nodule had come up. So these are the cases where if you do galactomannan, if suppose the galactomannan comes positive, try to think about, can it be a false positive? If it is not, try to do the test again. If both the test comes positive, then start thinking that you are thinking a case of invasive aspergillosis. You may start preemptive antifungal in that situation. So you have to correlate with the patient. Suppose the patient who is just in the hospital, say, came with a trauma, and you have done galactomannan and gives positive, you start antifungal. I will not agree with it. Think about what patient's condition, that whether it is a neutropenic patient, whether the patient you are, like suppose it is a hematologic group of patient, or as I mentioned in the ICU, certain risk factors are there. Imaging gives you some suggestion, clinical picture gives you some suggestion. Then you start thinking that how you can correlate with it.
So that, I think that has answered a few more questions which were there. And just one last question, because we've kind of exceeded our time and it will close at 6:30. Role of serum IgE and aspergillus specific IgE in pulmonary aspergillosis.
See, this is very important, not in case of invasive pulmonary aspergillosis. See, aspergillosis vis-a-vis the lung, it is a very unique condition. Unique in that sense, it is an extended spectrum. At one end, if the patient is immunosuppressed, we get invasive aspergillosis. On the other side, if the patient is immune intact, especially hyperimmunity is there, then you can see allergic bronchopulmonary aspergillosis. Now, this specific IgE or total IgE helps in diagnosis of allergic bronchopulmonary aspergillosis. It does not help in case of invasive aspergillosis. In chronic pulmonary aspergillosis, we try to look into it, but it is not so much helpful. Rather, it is the IgG detection that is very useful in case of chronic pulmonary aspergillosis. So I would say that either if it is a aspergillus induced or aspergillus induced, there is a which is called excitement or more immunological reaction is there, or if there is a ABPA is there. In those situations, it is the specific IgE and total IgE estimation helps. You can go through our paper, especially Ritesh has published it. That is very important and gives a very good diagnosis how to go for ABPA with this specific IgE and total IgE estimation.
Sir, thank you so much. A very exhaustive discussion and a very exhaustive presentation. Thank you so much, sir. And few of the students are asking for the PPT, but that I can answer, sir. This video recording will be available on our YouTube channel, that is IMMPG Masterclass. And please subscribe, join, and view this presentation. I will try and upload it as early as possible on our YouTube channel so that you can also see this and learn more. Thank you so much again, sir. Thank you, Aarti ma'am and Shirwal sir also.
Sonal,
Thank
Shirwal,
you.
Aarti, all of you, thank you very much for giving me this opportunity. Thank you.
Thank you, sir, for the beautiful talk. So difficult to access this information otherwise.
Okay.
Okay, sir.
Bye.
Thank you.
Bye.
Sherwal sir, I think sir had to go for a meeting. I think he is left. All right, so we'll log out then. Thank you everybody for attending.
Thank you.